Hello, I am Caitlin Cilio from the University of Texas at San Antonio, and today I'm going to be doing a 10 to 15-minute presentation for our World AIDS Day webinar. I'm really pleased to be part of this, and thanks so much for tuning in. This will be a quick overview of this study and its findings, and I look forward to getting into more detail and discussion during our live webinar, so please do tune in for that. The title of this talk is The Multi-Level Influence of Gender Norms in HIV Care Engagement and Qualitative Study in Uganda. So just some quick background to start. The study is motivated by gender disparities in HIV outcomes that are present in Uganda, but also throughout sub-Saharan Africa and other regions globally. So you can see in this slide, women in Uganda are more likely to be HIV infected compared to men. However, men have worse viral load suppression than women across all age groups, as displayed here. Viral load suppression is an indicator of viral load non-suppression is an indicator of poor treatment adherence. And so this is really a result of worse engagement across all stages of care among men compared to women. So research shows that men are less likely to know their status through HIV testing, more likely to delay in linking to care after finding out their status, and then have worse treatment adherence and clinic appointment attendance compared to women. And from an epidemic control perspective, population level viral suppression is really the ultimate goal, as it reduces the spread of HIV by making people living with HIV non-infectious. And it also improves the health outcomes for people living with the virus. As a result of this worse viral load suppression and engagement among men, men in Uganda are more likely to die of AIDS-related illness compared to women, despite women being more likely to be infected. So gender inequity and gender norms shape these HIV disparities, which has been a focus of much of my work to date. Gender norms are the culturally grounded expectations for women and men's roles, behaviors, and relationships. In this study, we took a social ecological approach to exploring the role of gender norms in the community and how these create multi-level barriers to patients' HIV care engagement at the health system, interpersonal, and individual levels. We use the social ecological model to guide the study, which is displayed here on the slide. So very briefly, this is an overview of the methods, which was a qualitative study. We conducted the study in partnership with a community-based organization known as Mildmay Uganda. Between June and September 2020, we conducted 7 focus groups with HIV patients, providers, and community members, and 15 key informant interviews with HIV stakeholders. So that included folks from the district health teams, facility in charges, and representatives from other community-based organizations. Data were analyzed, guided by the social ecological model through an iterative process of thematic analysis. So getting right into the results, this again is kind of a broad strokes overview of what we found, but at the community level, we explored what gender norms were prominent in the region. Norms that asserted men's subordinate status and, women's subordinate status and men's dominant status were prevalent. So traditional gender roles were also apparent, including men's role as provider, head of household, leader in the community, and women's role as homemaker and mother. As for men and women's behavior, it was generally accepted that women should be submissive and traditionally feminine, while men were meant to be strong, self-reliant, and emotionally inexpressive. In the next slides, I'll discuss how these norms and roles interact and drive factors across different ecological levels to affect men and women's care engagement. At the health system level, when health workers and district leaders were asked about male and female friendly aspects of care or programs specifically aimed to reduce gender disparities in care, a number of efforts were named. These included gender-based violence-related trainings and community testing outreach efforts to reach men. However, the implementation of these programs were inconsistent. For example, although gender-based violence training was mandatory per Ministry of Health guidelines and meant to be implemented in all districts, many providers had never received the training. In addition, the priority and perceived importance of addressing gender disparities varied among respondents. For example, an assistant district health officer stated that such programs were low priority as displayed in the quote on the slide. This individual goes on to say that patients have that, why should you take this person? We're all sick. So what is different with a woman that a man is not suffering from? This quote highlights an attitude that was present among some leadership that it might be unjust to treat men and women differently. Therefore, gender-specific programming was viewed as unethical and misunderstood by providers and leadership. Two types of relationships had high importance for care engagement and were shaped by gender in our data: that of the patient and provider, and those between intimate partners. In each, the issue of power imbalances were prominent. While health workers have status and power tied to their role of health worker, the status was said to sometimes clash with men's expected status tied to their gender. So if we consider the quotation on the slide, one respondent in the men's focus group said, "The other thing is ego. If he, the male patient, finds a younger health worker who's going to treat him, he says to himself, I'm an old man, what am I going to tell that one? And yet, you are the one who's going to help him, but he has the ego. He would rather stay with his secrets." Another respondent said, "A man would not want to talk to the health worker if he finds that she is female, yet his issues are sensitive." Moderator probes, "So do you mean that a man prefers a fellow man as a health worker?" And all respondents in the focus group agreed. So here we see an issue with a man's willingness to take advice from a younger man, as well as from female providers. So here power dynamics are at play, but this also relates to norms around men's emotional inexpression and gendered communication. Further, it ties to a broader health system level barrier that we found, which was that there are far fewer male providers to tend to male patients than female providers. In addition, power imbalances in intimate relationships tended to disadvantage women and negatively affect their care engagement, driving issues of non-disclosure, partner violence, and fear of abandonment among women who are often financially dependent on men, all of which were barriers to ART adherence. Finally, at the individual level, for men, community gender norms that assert men should be strong, self-reliant, and emotionally inexpressive were described as common drivers to men's care engagement. HIV was commonly viewed as a threat to several aspects of masculinity, including men's family role, their ability to provide, the respect they feel is due to them from their family and the community, and their relationships with women and their sexual lifestyle. The quote on the slide demonstrate how men fear HIV status disclosure could hurt their status as the head of household and could reduce their care engagement. So in reference to finding out one is living with HIV, a man in the community focus group said, with the man's family, his wife starts to distrust him as well as his children despising him. Children look at the father as useless and begin to think that they have no future because it is the father that has gotten infected, yet he's the upper hand of the family. So you can here you can see HIV being viewed as a threat to men's status within the household and their role within their family. And this was commonly discussed as one example of how masculinity and masculine norms were a barrier to men disclosing their status, being known positive in the community, and their fear of stigma, which were all barriers to care engagement. In addition, conflict with work hours and priority being placed on earning and men's role of provider conflicted with men's clinic attendance, as being too busy for clinic appointments was commonly cited as a barrier to care engagement for men. What we saw at the individual level for women was societal level gender inequity, including unequal opportunity for education and earning and women's role as caregiver manifested at the individual level in the forms of poverty-related barriers to care engagement. This included women having financial barriers to care, like the cost of transportation, food insecurity, and the burden of childcare, creating problems for women's adherence to art and clinic appointments. Women's financial dependence on men was also a result of these broader inequities in women's opportunities, and that interacted with the relationship level inequities that we discussed in the previous slide to negatively impact women's care engagement. So this could include examples like being stuck in an abusive relationship or not being able to disclose one's status to their partner, which were both independent and related drivers to poor care engagement for women. So very briefly, this is really a broad overview of some implications I hope we can discuss as part of the webinar more in depth. But the broad implications for the study, I think, point to the need for gender transformative HIV programming across ecological levels. And that gender transforming programming is that programming that shifts gender norms to be more equitable in order to improve health. So some examples of that might be institutional efforts to address gender-based violence and engage men, particularly strengthening the implementation of existing programs and creating new programs. Gender-specific trainings for HIV providers that could help providers understand men and women's barriers to care and better address them. And then community and individual sensitization to alter harmful gender norms that impede men and women's care engagement. So I'd like to thank our study participants, Mild May Uganda, and the clinics we collaborated with, as well as my study co-authors who are listed on this slide. Feel free to get in touch with any inquiries using my contact also listed on the slide. Thank you so much for listening. And I hope that you attend our live webinar where we could have a more in-depth discussion about this and this topic generally. Thank you so much.
Good morning, students. I'm Nutria. I'm from 11 Maret University. I'm a fetal-maternal consultant from Obstetric and Gynecology Department. It's a pleasure and honor for me to give a lecture about HIV in pregnancy, especially in Indonesia. Let's start the lecture. I'll share the screen first. Okay. Yeah, HIV in pregnancy. As we know that HIV in pregnancy in Indonesia is still a big problem, which the government of Indonesia have a program that called Indonesia Getting to 3.0, which means the triple elimination of HIV, syphilis, and viral hepatitis B transmission from mother to child. To achieve that, we have a 390 acceleration, the fast track of 90-90-90, which means that 90% knew the status, 90% get the ARV therapy, and 90% suppress viral load on ARV therapy. And the main goals in 2030, which is we have the 3.0, this is the 0 new infection, 0 AIDS-related death, and 0 discrimination for the HIV positive. The program planning is started in 2013, and then in 2019 we have goals that 90% know the HIV status and 100% screening HIV in pregnancy. And now the 2022 we have a triple elimination screening, and the target in 2027 we have 90-90-90 for the fast track. And the situation analysis, the global goal is to end the epidemic of HIV, syphilis, and viral hepatitis as public health threat by 2030. The triple elimination of mother-to-child transmission from WHO have goals that the first in the new cases HIV in children less than 50 per 100,000 live birth per year, and less than 5% breastfeeding population and less than 2% non-breastfeeding population. To achieve that, we have a condition required high quality and complete antenatal care coverage for HIV, more than 95%, and treatment coverage as high as possible, which is more than 95%. To get that, we have the intervention. The first is prevent unwanted event, and the second one is intervention from prevention mother-to-child transmission at pregnancy, especially at antenatal, childbirth, and afterbirth. The treatment of ARV, and we have the goal single rate less than 50 per 100 live birth per year. As we know that in UNH Global HIV Data 2018, 34 million people living with HIV in the world, with 50% are women and 2.1 million are children ages less than 15. In Southeast Asia, including in Indonesia, 1.3 million people, or 37% women, infected by HIV. And the number of women infected by HIV is increasing from year to year. And estimated 2,000 children in the Asia Pacific have HIV positive without treatment. How about in Indonesia? HIV in Indonesia, the case was first reported in Indonesia in 1987, and it fastly growing. 30 years later, 2018, HIV AIDS spread almost 69.4% in all regions. The highest sources of transmission is through unsafe sex. And we have data that 2018, the largest group of AIDS cases was in a housewife group. If they are pregnant, potential transmits to their baby. And what is the triggers of what is the predisposing factor of HIV transmission in Indonesia growing fastly? The Indonesia is having a large population, more or less 240 million people, which is 1.69 million women married to high-risk men. And so if they are pregnant, it's very dangerous to spread to their baby. So according to WHO guidance in 2014, from the antenatal care coverage, the Indonesia is just 93.9, and the coverage of testing, the Indonesia is just 24%, and the antiretroviral treatment coverage of HIV in 2014 from WHO guidance is more than 90%, but in Indonesia is still 13%. And the treatment of syphilis, also the AIDS, it is just low for the coverage. So we have a early screening program in antenatal care, also include HIV tests, and the test is being done for the 3 times, 1, 2, and 3. And from the antenatal care, we have guidance to giving the ARV fixed drug combination, 1 tab per 24 hours in a lifetime. And for the infant, we have the prophylaxis of antiretroviral and cotrimoxazole prophylaxis. Also, we done the PCR test in 4 until 6 weeks. HIV in pregnancy, the presence of an HIV or AIDS infection in a woman while she is pregnant. There is a risk of HIV transmission from mother to child in 3 primary situations. The first one is from genital fluids. The second one is from blood or tissue contamination, and the third one is from perinatal. From the third above is the important thing that is in perinatal, transmission from mother to fetus or infant during pregnancy through an infected placenta, contact with blood or genital fluid during delivery, and through breast milk during lactation. As we know that HIV infection in pregnancy, so the HIV or specific retrovirus attack the immune system for the immunocompromised person. In the pregnancy is including in an immunocompromised condition. So it's easily getting infected. So if we didn't treat it well, it became an AIDS and infection of opportunistic. But the progression of the infection is very slowly, maybe from the 2 until 15 years. We have to know the risk factor, the mother-to-child transmission, especially for the general practitioner, that we have the early screening in first medical facility: the mother, the obstetric factor, and the baby factor. From the mother factors, levels of viral load in the blood, the CD4 levels, and the nutritional status during pregnancy. Infectious disease during pregnancy, also the breast problem if she is breastfeeding. In obstetric factor, this is a mode of delivery, duration of labor, premature rupture of membrane, also episiotomy, vacuum extraction, or forceps. In the baby factor, it's due to prematurity and low birth weight, duration of breastfeeding, if without treatment, or the source in the baby's mouth if the baby is breastfeeding. The sign and system on the three main stages of HIV infection, maybe we can refresh about it. The first one is called acute infection, or we can call in here is a window period, that the body has been infected with HIV, but no anti-HIV antibodies found. So just a mild symptoms, or maybe we didn't know that the person is infected by HIV. The second sign is from clinical latency. It became a mild symptom, or maybe it can be asymptomatic. And the third phase is the AIDS. This is the severe stages. From the clinical staging by WHO, it's classified by stage 1 until stage 4. That is, which is the stage 4 is the severe disease or acquired immunodeficiency syndrome. From the CDC classification, the HIV based on the CD4 count, that the stage 1 is CD4 count more than 500 cells, and the stage 3 is CD4 count less than 200 cells per microliter or age-defining condition. So to stop transmission, we have the mother-to-child transmission prevention, or PMTCT, that is a service provided to reduce the risk of mother-to-child transmission of HIV. It depends on several parts, from the health system, from the regulation, from the guideline, and then from the sexually transmitted infection and community engagement. So we have a global strategic response that we have to prevent the primary in prevention and prevention of pregnancy in HIV women. So the main problem is to get the prevention of mother-to-child transmission with ARV, safe obstetric practice, and safe infant feeding. The time and risk of mother-to-child transmission of HIV, the risk of transmission without intervention is 20 until 50%. But if we have a prevention of transmission, can reduce up to 2%. The main or the most percentage, if we have the delivery time, which is from 36 week gestational age until delivery or during delivery, it is 10 until 20% of infected during the labor. And the risk of mother-to-child transmission with intervention, it can lower with highly effective ARV. With the breastfeeding is less than 5%, but with highly effective ARV but no breastfeeding is less than 2%. How about the mechanism of transplacental transmission? The placenta is a barrier, prevents transmission of viral, but still allows others to reach the fetal circulation. So the HIV transmission to the placenta influenced by maternal viral load and maternal immune response, also the presence of pathological condition of the placenta. The main HIV-1 receptor is CD4, which is recognized early in the pathogenesis of HIV. And HIV-1 genomic material has been detected in placental macrophages, cytotrophoblast, and syncytotrophoblast. In a many studies, histological examination of the placenta from HIV patient revealed HIV-1 infection on cytotrophoblast and syncytotrophoblast, also in endothelial cells. The effect of HIV on pregnancy, we can make the increases of the risk of spontaneous abortion, stillbirth, premature birth, low birth weight risk, pneumonia, UTI, and postnatal infection. The target of PMTCT is encouraging access of ARV, reducing HIV infection in children, encouraging access of care for infants exposed to HIV, and also encouraging timely treatment and care for families to reduce the number of orphans. We know about the national strategy of PMTCT. According to the WHO2, we have a prong 1 until prong 4. The first is primary prevention of HIV in women of childbearing age. The second one, the prevention of unwanted pregnancy in HIV woman positive. The main in here is the main goal is pregnancy planning. So we have two aspects. The first is medical aspect. The planning of pregnancy if undetected of viral load or CD4 count is more than 350 cells per millimeter and the free from opportunistic infection. The social aspect is from the both parts, from the men and the women, especially women. She has to understand the risks and consequences of pregnancy, childbirth, and childcare, as well as agreement or approval from the family. The prevention of transmission of HIV positive women to children. This is the problem in here. We have the HIV testing, and then the ARV therapy, and then the safe delivery, and also the information, counseling, and support about infant feeding, referral for management, also for social support to the mothers and family with HIV infection. The third one, the prevention of PMTCT. This is the problem management HIV in Indonesia. The first one is the coverage HIV testing is still low. The ARV therapy also still low, and safe delivery also, and family planning management. Flowchart HIV testing in Indonesia, we have done the triple testing from A1, A2, until A3. The positive result is A1, A2, and A3 are reactive, and the negative result is A1 non-reactive, but A1 is reactive. Repeats, A1 and A2 are non-reactive. One is reactive but no risk. Also inconclusive, that is two reactive results, but one reactive test, but the risky or the partner is at risk. Management HIV in pregnancy from the antenatal care. We have HIV counseling and testing during ANC, and then the important for the ANC in HIV positive woman, that is, we have to know the history of the HIV related illness, and then how long the HIV status, and then examination and assessment of symptoms of AIDS and HIV in children and partners. And then we have a treatment of HIV related disease, also the looking for potential factor inhibit action of ARV. The additional laboratory test is CD4 check routinely, and the opportunistic infection diagnosis, also the follow-up of ARV. Prophylaxis and treatment of opportunistic infection, screening of in here the tuberculosis or the malaria, and then short-term ARV prophylaxis to reduce PMTCT during pregnancy. Also the baby care counseling on signs and symptoms of HIV or AIDS if hidden progression. Intrapartum, we have a program that the partus have to in a professional health workers or in tertiary facility of medical and identification of danger sign. Also avoid invasive procedure like amniotomy, vacuum or forceps, safe delivery to the protect health workers, mother, families, and baby. Also HIV testing and counseling during delivery. In postpartum care, we have a postpartum care at 6 hours, 6 days, and 6 weeks postpartum for the mother and baby. Continue the highly ARV if the patient is receiving highly ARV, but or the start HIV ARV in patient who have not received the ARV. How about the mode of delivery? In here, we don't say that we have to do the cesarean section, but we plan in C-section. We educate the patient to get the C-section based on the viral load. So if 36 week gestational age, we usually check the viral load. If less than 40 or undetectable, we can plan the vaginal delivery. And if it more than 400 copy per milliliter, we can plan the C-section. And then for the viral load, if in another copies, if less than 1,000 copies per milli in 36 weeks gestational age, we can do vaginal birth. In the C-section delivery, the risk of MTCT increased 2% each hour after the rupture of the membrane. So if we have the rupture of the membrane, we do the C-section. And C-section before labor or rupture of membrane reduce risk of, if we have rupture of the membrane, we didn't do the C-section because the C-section before labor or rupture of the membrane reduce risk of MTCT by 50 until 80%. But there is no evidence benefit of C-section after onset of labor or membrane rupture. So if it in a latent phase, so we can do the C-section. But if the delivery is becoming in second stage, we do the vaginal birth. How about the postnatal care? The postnatal care advises not to breastfeed and continue support care, therapy, and management. Also, family planning. This is the important one. We do the long sterilization with intrauterine device, and we have to many educate about the healthy lifestyle. ARV therapy for pregnant women with HIV. Protocol administering ARV therapy to pregnant women with HIV. The drug used is combination, fixed drug combination taken once a day so that patients are more obedient. If before pregnancy already taken ARV, continue with the same combination of drug during pregnancy. If during pregnancy just found HIV positive, so ARV is given regardless of gestational age, CD4 status, and disease stages. For pregnant women whose HIV status is known at the time of delivery, ARV is immediately given. The ARV treatment principles is ready to receive, obedient, discipline to taking medication and doctor's control, actively ask the doctor about therapy, and regular checkup according to doctor advices. In Indonesia, we have a lot of guidelines, but in the last one is expert panel in 2013 that ARV started as early as possible, regardless gestational age, clinical stages, and CD4 count. So with early initiation and then monitoring the success of ARV therapy, and we can check the viral load at 6 until 12 months since starting ARV, and thereafter IV 12 months. And we have also monitoring antiretroviral treatment resistance. Okay, that's it, my presentation about HIV and pregnancy, especially in Indonesia. See you next time. Thank you.
Hello, I am Dani Radono, internist, tropical infection consultant, University of 11 Maret, and a chief of the HIV program at Muardi Hospital. I am very excited today to talk to you about topic current update HIV/AIDS during COVID-19 pandemic in Indonesia. HIV and COVID-19 are currently an infection that is a problem because it is interconnected and can be fatal if both occur simultaneously. Control of HIV in Indonesia is set in the Ministry of Health Regulation with the achievement of 3.0 in 2030, including no new HIV infection, no deaths due to AIDS, and no discrimination. However, 10 years into 3.0, the COVID-19 pandemic in 2020 reached 550,000 cases, consisting of 490,000 HIV and 129,000 AIDS. Especially during the COVID-19 pandemic, 50,000 cases of HIV/AIDS have been detected. Globally, HIV control in Indonesia show good result. Indonesia commitment to the fast-track approach 90. 1. Detect infected people in 19% of people estimated to be infected. Number 2, provide early antiretroviral therapy in 90% of infected people. And number 3, it's undetectable viral states in 90% of people taking ARV. The purpose of the fast track is to achievement indicator of Sustainable Development Goal of SDGs. This is a map of cases in the world, where in 2090, there will be around 38 million people living with HIV. The total infected is 76 million and new HIV infection is 1.7 million. With the death rate is 690,000 cases. This is case that occurred in 2020 in Indonesia, with an estimated incidence of 543,000 HIV cases, with the majority of cases in Papua, Jakarta, West Java, and East Java, with a prevalence of more than 30,000 cases. The highest prevalence of HIV case at the age of 20 until 29 years. This means that HIV transmission has occurred at the age of less than 20 years of adolescence. Some of the problems that arise at this time include lack of understanding of patient and the public about modes of transmission and prevention, lack of understanding of health workers on effort to control HIV infection, lack of integrated HIV service, reducing the risk of stigma. The number of HIV tests carried out in the community is still low. An equal distribution of HIV tests and ARV drug can be reached by the whole community, and high loss to follow up. How to improve HIV finding? The first, make it easy for doctor in charge of to screen patient for HIV. Activate for HIV screening. Program for all pregnant women are tested for HIV. Always remind TB if HIV collaboration in TB.clinic, and do examination HIV test for hepatitis B or C patient. This is after the implementation of the new normal rules and the application of health protocol to health facilities, and also key population as well as coordination of program implementation from the Ministry of Health and the community. This graph shows the discovery of new person living with HIV in 2020 at the beginning of the first quarter was higher than 2019. In April, May decreased, but in June saw an increase in new cases. The target for controlling HIV cases before the year 2030 is to activate the 90-90-30 program. Zero new infection, zero AIDS-related death, and zero discrimination. Ongoing program is find more people with HIV, treat 45% of people with HIV, test and treat to viral suppression 90% of HIV ART, and keep person living with ART. Program of HIV and AIDS control until the year 2024 are 90% gay population receive HIV transmission preventing program. 72% of K population and 90% of other at-risk population receive HIV testing services. 91% of persons living with HIV/AIDS cumulatively know their HIV status. 75% of persons living with HIV/AIDS are receiving ARV treatment. 90% retention of people living with HIV who are on ARV, and 95% of people living with HIV who are on ARV treatment have succeeded in suppressing the number of virus, decreasing until there is no discrimination against persons living with HIV/AIDS and K population. Target population consists in two groups, K and special population. A group that are included in the K population are sex workers, men who have sex with men, transgender, and injecting drug user. Special population are pregnant mother, TB patient, hepatitis patient, and person living with HIV/AIDS couple. How about vaccine COVID? Survey from the Indonesian National Network HIV involving 100 respondents, most of whom are of productive age, aged 30 until 39 years, is 41%. From this data, it appeared that more than half of the respondents who are willing have been vaccinated, and the other half have not been vaccinated. People living with HIV/AIDS who have been vaccinated, 31% of respondents admitted to receiving the vaccine because of self-awareness. Daring to prevent HIV/AIDS transmission during the COVID-19 pandemic is talking. The HIV/AIDS epidemic include myths and the rejection of condom. In addition, there are also issues of gender equality, where condoms are only aimed at men. Well, there are types of female condom that can also set with women in making decisions to use HIV prevention tool, especially of risk behavior. Most people still think that HIV is transmitted through shaking hands, hugging, kissing, using shared eating, untesting, swimming together, mosquito bites, using people toilet, and other was information is not accurate. How about HIV in pandemic COVID? The existence of a social restriction policy during the COVID-19 pandemic is also a dilemma for effort to overcome HIV/AIDS. In addition to stigma and prevention effort through the use of condom, there are dilemmatic problems that have arisen during the COVID-19 pandemic, include lack of optimal socialization and education of HIV/AIDS prevention, delay in the implementation of mobile VCT or HIV tests in at-risk population, due to limited resources and being diverted to COVID response, limiting access to antiretroviral therapy, and a greater risk of susceptibility to people living with HIV/AIDS being infected with COVID. The last one is summary. The prevalence of HIV case in Indonesia increased during the COVID-19 pandemic in the last 2 years. Indonesian program in line with WHO is 3-0, 0 new infection, 0 AIDS related death, and 0 discrimination. COVID-19 is currently on a downward trend because of the successful mass vaccination program, but not all people with HIV have yet been vaccinated. There are many problems with HIV, especially stigma and how to prevent using condom and limited access to ARV and delay in diagnosis are also problems. Thank you for your participation. Hopefully it can be useful. Terima kasih, matur nuwun. See you.